Okay, so let's do some cases in radiology. I'm just practicing, so I may be wrong. Let's do it together. So we are starting with the first case that I have no idea what it's going to be. So we have no clinical presentation supplied by the author, and we only know that this patient is an adult patient. Now this case has been tagged as legacy as it no longer meets image preparation and or other case publication guidelines. Okay. So let's see the images. We don't have scrolling, but okay. What can we see? There is a little bit hyperdense area like osteophytes, and if we can see the space of the joint between the vertebrae, quite thinner, quite dense. On this axial projection, I can't see too much pathologies. Maybe this. Okay. So defining no contrast city of the lumbar spine, there was a strip of fat density located within the dura and extending from the superior aspect of the L2 to L3-4. I think this is the strip of fat density. Okay. The generative disc changes at L3, L4. I think this is what it means. Osteophyte is present with marked disc height loss here and plate sclerosis. This is the plate sclerosis. On these images, the location of the conus cannot be identified but can be assumed to be at or above the level of L1, L2. Now, what does it mean? We're looking on MRI. We can see this. No. Here is fat suppressed. Okay, MRI confirmed the presence of the fatty tissue, high T1. Here, this is the fatty tissue in the area of the conus, around the area of the conus. T2 suppressed on fat saturated, extended from the conus to at least L5. The conus is located at L1-2 and is normal in appearance. The generative changes noted once more. Those are the generative changes. Okay. This case is a typical indication of a lipoma of the film terminale in a patient symptomatic for degenerative changes. The absence of low-lying conus and relative thin filum further suggests that this is an incidental asymptomatic finding. Okay, so it was a lipoma of the filum terminale, which is this area over here. And it is probably asymptomatic, and the symptoms of the patient probably come from these degenerative changes of the spinal canal. Okay, this was a case of the lipoma of the filum terminale. Let's go to the next case. History of a single episode of urolithiasis. Currently asymptomatic evaluation per request of urology. 50 years old female. Okay, so let's see if we see any stones. It doesn't seem so. Okay. Here are the calyx. Okay. There are no classification. I don't see any stones. It's right. A resting city of the abdomen and the pelvis did not show any renal stones. On IVB, the X-ray trendy enhancement of the medullary pyramids with a paintbrush appearance. No filling defect is seen in either kidney. Okay. Renal tubular ectasia, this paintbrush appearance overlap with medullary spongy kidney. and difference between the two is really of degree of symptoms. Renal tubular ectasia, less pronounced than medullary spongy kidney, asymptomatic incidental, no classification. Medullary sponge kidney more pronounced than renal tubular ectasia, predisposed to medullary nephrocarcinosis and renal stone formation. Okay, this was a very interesting case, but wait a second. Renal spongy kidney. Medullary sponge kidney is a sporadic condition where the medullary and papillary portion of the collecting ducts are dysplastic and dilated. In most cases, develop medullary nephrocarcinosis. Most patients with medullary sponge kidney remain asymptomatic throughout life, with the diagnosis only made incidentally when the renal tract is imaged for other reasons. Patient with complication SR 10%, including urinary tract infection, hematuria, and renal lithiasis. Okay. Medullary and papillary portions of the collecting ducts are dysplastic and dilated. Dysplastic and dilated. Okay, let's continue to the next case. So we have an acute severe abdominal pain, epigastric and lower abdominal tenderness in 55 years old male. Severe abdominal pain, epigastric and lower abdominal tenderness. Okay. Let's look at this one. Let's start over. So this is the liver, this is the stomach, this is the spleen, this is the gallbladder. I don't have too much to say about the liver. Subcapsular or something. Okay, what about the spleen? Spleen looks okay. What about the kidneys? This kidney, right kidney looks fine. Left kidney looks fine. Okay. What about the stomach? Pretty dilated. Maybe ate something. Okay. What about the pancreas? Epigastric pain, but I don't see any pancreatitis. The pancreas look fine. No fat stranding. No edema. Okay, so the pancreas look fine, quite fine. Bowel loops. Maybe there is an Audi sign. Okay. Bladder looks fine. So what's the problem? Epigastric pain. It's not the pancreas. It's not the gallbladder. It's not the kidneys, and there is something subcapsular here. Okay. The bowel looks quite fine. Don't see anything too dilated. Okay. Arterial phase. Let's look on arterial phase. Okay, this one is hard. Portal venous phase. Let's look at the appendix. I didn't look on the appendix. Where is the appendix? This one? This may be the appendix. Wait. Maybe this one. But it seems like just a bowel loop. So this is the appendix? No, of course not. So where it is? Where is the appendix? Hello? This one? Maybe this patient just have an appendicitis? Let's try to look right over here for the appendix. So yeah, right over here. I can't see the appendix quite clearly. Where is it? Where are you? Let's look again, just the liver, spleen, pancreas, kidneys, vertebral columns. Now, where is the appendix of this patient? I can't get it. Maybe this one? Maybe that one. It doesn't look with any stranding around it. Okay. Okay, mild to moderate dilatation of the small bowel loops with associated right iliac fossa transitional zone. It is associated with crowded bowel loops, mesenteric congestion, and fat stranding within the right abdominal quadrant. It is intimately related to small bind ending outpouching with thick enhancing wall, with an associated small amount of peritoneal flexion fluid. So it seems that they are telling me that there may be a small bowel obstruction, crowded congestion, and fat straining with right abdominal quadrant is intimately related to blood and outpouching with increased abdominal small amount of peritoneal flexion fluid. Right region has some dilatation of the bowel loops. This is the transition zone probably because of the fecal content that I can see here. Okay. The patient underwent surgery with inflamed diverticulum with consequent small bowel obstruction. This was the diverticulum, not the appendix. Oh my god. Oh, maybe it's not a diverticulum, so what it is? Yes, the diverticulum. Oh my god. Nice one. So megadiverticulum is a true diverticulum, also known as vestigial remnant of the omphalomesenteric duct. It is considered the most common structural congenital anomaly of the GI tract. The mechanism of obstruction may be due to trapping of bowel loop by mesodiverticular band, extension uterine hernia sac, litter hernia, or interception. Hemorrhage is the most common complication of megadiverticulum. Interstitial obstruction is the second most common complication of megadiverticulum. So this was quite a hard case. Maybe I'll do just one more case and we are finished for today. Bilateral visual loss in a 35-year-old female. Bilateral visual loss, 35 years old female. Now, 35 years old is quite an age for multiple sclerosis, for example, but bilateral visual loss from multiple sclerosis sounds quite unusual. We have the MOGAD and NMOG that may be. Now, bilateral visual loss at the same time. Okay, what can it also be? Something that maybe pressure on the chiasm, but it won't do bilateral visual loss. Bilateral visual loss. What can cause bilateral visual loss? Okay, let's see. Okay, this is causing the bilateral visual loss. It's really in the area of the sella turcica. It's probably from the pituitary, but now we need to understand what the hell is it. Okay, you don't really need to too much look for it. Doesn't really look like a macroadenoma. It looks like a, I don't know, different types of tissues inside it. Teratoma or something. Because macroadenoma, which may be the most common tumor in the pituitary, macroadenoma prolactinoma, but it doesn't really look like. Maybe it is. It more looks like something with different types of tissues. Maybe hemorrhage with clots inside. But what can hemorrhage? Oh, maybe Sheehan syndrome, but they didn't say that she is after pregnancy. So why would it be Sheehan syndrome? But there is a level of fluid. Maybe it seems like there was a bleeding inside, and Sheehan syndrome may be with such. Maybe Sheehan syndrome. So a mass causing ballooning of the cell with large supercellular component. It has areas of T1 hyperintense and fluid level demonstrate Blumina artifact on T2 star sequences representing intratumoral hemorrhage. It showed moderate enhancements post-gadolinium administration. Compressive mass on the optic chiasm and the midbrain is noted. There is extension into the cavernous sinus with the vascular encasement on the left. So now case discussion, and final question was pituitary macroadenoma with intratumoral hemorrhage. So it really was a pituitary adenoma, but there was a intratumoral hemorrhage. Histologic sections show fragment of neoplastic lesion composed of sheets, nets of cords of round polygonous cells which have encompassed nuclei, delicately stippled chromatin, and moderately abundant cytoplasma. Telangiectasia is uncommon and mitosis are rare. Pituitary adenoma. It just was pituitary adenoma. Okay. So maybe one last case. Right flank pain in 10 years old female. Right flank pain in 10 years old female. So we need to think about the kidneys, ovaries, ectopic pregnancy. This is too young for ectopic pregnancy. Maybe something with her. No, hymen, imperforated hymen is also too early. She needs to get her period in about 2 years usually. So no, right front pain, so kidneys, kidney stones. What else? Maybe ovaries with some cyst inside. What else? Right flank pain. Maybe gallstone on the gallstones. Maybe urinary tract infections with pyelonephritis. Let's look at ultrasound. So we really see some anechoic lesion with hyperacoustic shadowing, so it probably a cyst. But where is this cyst come from? Okay, there is a large unilateral cyst running from the right kidney. Maybe this is the remnants of the kidney. With homogeneous construct extended to the Morrison pouch, no detached membrane is seen. On CT, we are seeing the cyst very clearly. On the right side, barely seeing the enlarged kidney. There is well-defined border for this cyst with hypodense contents relative to the kidney tissue. It doesn't undergo contrast enhancement nor the borders of the lesion. It looks like a cyst, but what can cause such a large cyst? It's not polycystic kidney disease because it's unilateral and only one kidney. What else can we see? So this is quite a large cyst. Okay, there is a large vertical renal unilateral cyst with homogeneous fluid content and high attenuating wall on non-enhanced images extending on the Morrison pouch with a mass effect on the liver, which is displayed superiorly. No enhancement is seen following IV contrast and mild dilatation with distortion of the calyx. The chest radiograph note show was unremarkable. Renal hydatid infection should commonplace. What? Is a very rare manifestation of hydatid disease seen in less than 5% of patients with hydatid disease. The patient went on to have a conservative surgical resection, which confirmed the diagnosis. Hydatid disease, hydatid cyst, autonomic echinococci, is result from infection by echinococci tapeworm species. It primarily includes two significant zoonotic diseases caused by tapeworm, cystic echinocosis, resulting from Echinococcus granulosus, and alveolar echinocosis, resulting from Echinococcus alveolaris. Okay, prime epidemic region and cystic differ, pathology, types of cyst, ultrasound, treatment, surgical excision, puncture aspiration injection of postcoital agent, chemotherapy with an inhalamic agent, anti-emetic agent, watch and wait for inactive and silent cyst. Okay, so this was a very interesting case of hydatid disease from this infectious organism. Quite interesting case. Okay, so this is for now. This is the series of cases, quite interesting series of cases. Thank you very much for participating in this radiology exercise from Radiopedia. This was totally random, and I didn't know that those cases would come up. Thank you very much. If there are any mistakes or correction, please tell me. Thanks for Radiopedia, and thank you all. And that is it for now. I think, yeah, maybe. Bye bye.